I'm Dr. Maryam Lustberg, Chief of Breast Oncology at EAL Breast Program, and I'm thrilled to be joined by three colleagues tonight who will give an update on the latest in breast cancer treatment. Our first speaker is Dr. Dan O'Neill, who is an assistant professor and a specialist in breast cancer. He practices in our Waterbury office and conducts research in New Haven and beyond. Dr. O'Neill will give an update on HER2 overexpressing breast cancer. Thank you, Dr. O'Neill.
Hey, thank you very much. Let me just share my screen here. All right, I hope that's working. So I'm going to present on recent advances and some ongoing clinical trials for the management of HER2-positive breast cancers. And so just as a reminder, so HER2-positive breast cancer or HER2 overexpressing breast cancers make up about 20 to 30 of all breast cancer cases. And in the United States, HER2 positivity was formerly a negative prognostic marker, but with the advances in available medications, give me one second, I'm going to use the pen here. With the advances in available medications, the survival outcomes for HER2 positive disease have really practically caught up to the survival outcomes for early luminal disease. And in the case of metastatic or advanced HER2 positive breast cancer, survival outcomes have actually surpassed luminal disease. So the landscape's changing pretty quickly. What I have to share is organized by sort of increasing stage. So I'm going to start with stage 1. The standard of care for stage 1 HER2 overexpressing breast cancer was established several years ago by the APT trial. So this was a single-arm trial. It took patients who had small tumors, node negative, and those patients went straight to surgery. And then afterwards, in the adjuvant setting, they received paclitaxel and trastuzumab. Even though it was just a single-arm trial, the disease-free survival outcomes were pretty extraordinary across the board. And good enough that this was practice changing at that point. The 10-year disease-free survival numbers were published earlier this year, and they were still north of 90%. So APT was then followed several years later by the ATTEMPT trial. And the ATTEMPT trial tried to maintain those excellent survival outcomes, but decrease toxicity related with therapy. Patients in that trial, again, were treated in the adjuvant setting. They were randomized to the APT regimen or to TDM1 or Kadcyla for a year's worth of treatment. The Kadcyla arm was non-inferior in terms of survival, so still excellent survival. They had a composite endpoint for clinically relevant toxicities, and there was actually equivalence between the two regimens in terms of composite toxicity. There was a difference in the distribution of toxicity types. So Kadcyla had less neuropathy and less neutropenia, but more thrombocytopenia, more hyperbilirubinemia, and ultimately led to more dose reductions. So ongoing right now is the ATTEMPT 2.0 trial, and this is another try at reducing toxicity while maintaining excellent survival in stage 1 HER2 positive breast cancer. So a similar set of patients are being enrolled, and they are being randomized to either what's still probably considered the standard of care, paclitaxel and Herceptin for a year, or a shorter course of TDM1, just 6 cycles of TDM1, with a transition then at that point to Herceptin to complete the year. The idea being to try to eliminate the toxicity that you get with the paclitaxel, but transition to Herceptin before you start to see toxicity from TDM1 really begin to pile up. So this trial is open nationally. It should be open very soon and available to patients at the O Cancer Center. Moving on to stage 2 and stage 3. So the standard of care for these patients involves neoadjuvant chemotherapy treatment before their surgery, and that contains trastuzumab and pertuzumab. There's a number of different chemotherapy regimens that are considered reasonable, some containing anthracyclines, some without anthracyclines. I think the most popular anthracycline-sparing regimen at this point is probably TCHP, docetaxel, carboplatin, Herceptin, and Perjeta. When patients who receive neoadjuvant therapy go on to their surgery, if they achieve a PCR, then they just continue on with adjuvant Herceptin. If they have residual disease, the Catherine trial, which was published, I think, in 2019, showed or established that if those patients transition to adjuvant TDM1, adjuvant Kadcyla, they have improved disease-free survival compared to continuing on with just trastuzumab. So this approach right now is considered standard. I mentioned that the TCHP was the standard anthracycline-sparing neoadjuvant regimen. There have been a couple of small phase 2 trials that have looked at some chemotherapy de-escalation options for the neoadjuvant regimen. I highlight a couple of those here, the Daphne trial and the West German Study Group ADAPT trial. Both of these trials had patients who received neoadjuvant paclitaxel and Herceptin Perjeta alone, so paclitaxel being the only chemotherapy. In the single-arm trials, these smaller trials, the PCR rates with that regimen were pretty good. So greater than 55% in the Daphne trial, greater than 75%, sort of incredible results here in the ADAPT trial. And these findings maybe not led directly to, but supported the conduct of another set of ongoing trials. So this is the Compass HER2 PCR trial. This is a trial that is open at Yale. Enrollment's nearly completed, but we have a pretty busy study schema here. If we just focus on patients who have stage 2 or early stage 3 disease, are being enrolled to neoadjuvant THP alone, so just a taxane plus Herceptin Perjeta. And then if they go on, when they go on to surgery, if they have a PCR, they continue with HP. If they have no PCR, they can receive additional chemotherapy at that time and TDM1. If the results in Compass PCR when this is presented are similar to the 2 studies I just showed, I think this will probably become a common approach as well. A sister trial that's ongoing for stage 2 and stage 3 patients is the Compass HER2 residual disease trial. This trial is also available at the Cancer Center. And this is a trial that takes patients who have already had their neoadjuvant chemotherapy, already had their surgery, and have residual disease. And they are randomized to TDM1, the standard of care, or TDM1 plus tucatinib. For those of you who are not familiar with tucatinib, tucatinib is another HER2 targeting drug, but it's a TKI. It's currently approved for combination therapy for advanced HER2 overexpressing breast cancer, but hasn't established a role in the early stage disease space yet. There are a couple of other trials that are ongoing nationally involving stage 2 and stage 3 HER2 positive breast cancer. But in order to sort of understand those, I have to introduce one of the newest drugs available for treating HER2 positive breast cancer. That is trastuzumab deruxtecan, or Enhertu. This is an antibody drug conjugate, just like Kadcyla or TDM1. There are a couple of things that make it distinct from TDM1. The first is just the absolute number of chemotherapy units that are attached to the antibody. So Kadcyla has 3 to 4 units of amastine linked to each individual trastuzumab antibody. And Enhertu has usually 7 to 8 individual units of the deruxtecan linked. In addition to that, deruxtecan is more lipophilic, and this leads to this pretty well-described bystander effect. Essentially, the idea is that that even cells that are adjacent to HER2-expressing cells are exposed and vulnerable to the deruxtecan that is brought into the into the area, into the tumor microenvironment, and this seems to lead to trastuzumab being a more effective drug as well. So in So there's a couple of ongoing trials using Enhertu for stage 2 to 3 breast cancer. The Enhertu trials are all titled Destiny Breast, and then they're numbered. So Destiny Breast 05 is a trial of patients with more advanced disease, stage 3 disease for the most part, who have received neoadjuvant chemotherapy, have residual disease. And patients in Breast 05 are being randomized to TDM1, the standard of care, or Enhertu for an equivalent length of time, just a strict replacement. This study has a disease-free survival primary outcome, and so reporting is expected in 2030. Destiny Breast 11 is a trial of looking at patients with a little bit earlier stage disease who have not been treated yet. And these patients are randomized to neoadjuvant Enhertu followed by THP, or a neoadjuvant regimen containing anthracycline and THP that is sort of the standard of care arm. Doesn't include any Enhertu. This study has just a PCR outcome, and so the primary outcome reporting is expected a little bit earlier, 2027. So moving on to advanced or metastatic disease, the standard of care for first-line treatment is still a triplet therapy that was established by the Cleopatra trial. That's a combination of trastuzumab and pertuzumab with a chemotherapy, usually a taxane. And then until pretty recently, the standard of care was pretty for second-line therapy was pretty firmly TDM1 in patients who had progressed on this triplet. The emergence of Enhertu, though, is beginning to change that. So first, there was the Destiny Breast 02 trial. This trial enrolled patients who had progressed on TDM1, typically in the second-line setting. And patients were randomized to either receive Enhertu as their next line of therapy or physician's choice chemotherapy. And you can see that the folks getting Enhertu, the blue line here, did substantially better, substantially longer progression-free survival with a hazard ratio of 0.36. That was pretty quickly followed by the Destiny Breast 03 trial, and patients in this trial were randomized at the point of choosing their second-line therapy. So they were randomized to either trastuzumab, deruxtecan, Enhertu, or TDM1. And again, the trastuzumab deruxtecan arm had substantial improvement in progression-free survival, has a ratio of 0.28, so a big difference here. These results, I think it's fair to say, have begun to change the practice patterns pretty quickly in the favor of Enhertu earlier on in treatment sequencing. Just presented a few days ago at ESMO were some combined analyses of participants from the first 3 Destiny Breast trials, specifically looking at patients with brain metastases and reporting on response rates and progression-free survival outcomes in those patients. So in the CNS specifically. So CNS overall response rates with Enhertu were reported at about 45%, and that was compared to 12 to 28% in the comparator arms, chemotherapy or TDM1. And CNS progression-free survival was also improved 12 to 19 months with Enhertu versus 4 to 9 months with chemo or TDM1. This, I think, is relevant because it helps kind of answer the question of if you have a patient with brain metastases and you're thinking about second-line therapy, do you need to worry that you're not getting good blood-brain barrier penetration with an ADC? And that seems like it's maybe not something that you need to be as worried about with Enhertu. Ongoing is the Destiny Breast 09 trial, which is sort of the logical next step. This is a trial of untreated patients with metastatic HER2-positive breast cancer being randomized to Enhertu plus pertuzumab or THP. And hopefully this trial's results will be available before too long. There's just a couple of other ADCs I'll mention. The first is trastuzumab duocarmycin. This is a DNA alkylating agent, also known to have a bystander effect. Its largest trial to date was the TULIP trial. And this was a trial of patients who had progressed on TDM1, so mostly patients in the third line setting. And they were randomized, just like Destiny Breast 02, to the ADC or to physician's choice chemotherapy. The PFS results were reported at ESMO in 2021, and they were pretty clearly better with the duocarmycin compared to physician's choice. The final overall survival results were just presented again at ESMO, and there was a numeric difference in favor of trastuzumab duocarmycin, but that difference was not statistically significant. So the FDA so far has declined to approve this drug based on the PFS data alone. So it remains to be seen what's going to happen now that there's overall survival data available as well. And then just lastly, I'll mention that there was a number of ADCs at ESMO that were in the kind of early phase setting as well. So probably not worth getting fixated on the overall response rates from these trials, but encouraging to see that there's sort of multiple drugs that seem to be in the pipeline, particularly with different types of chemotherapy payloads. So an MMAE chemotherapy, another topoisomerase 1 inhibitor, and even a novel immune stimulating conjugate with trastuzumab and a TLR agonist. So that's everything I have to share. I'm happy to take questions now, or I don't know if we want to do questions at the end.
Yeah, we can take a few minutes if there are questions. Thanks, Dr. O'Neill. To our audience, feel free to drop any questions in the question and answer chat box, and we'll either answer them through the chat or verbally. I don't currently see any questions, so I'll just ask you one quick one, which is, can you kind of elaborate a little bit more on brain metastases? You commented on some of the pooled data, and just in terms of how we think about sequencing our systemic therapies in CNS metastases, particularly in HER2-positive disease.
Yes. So I alluded to the fact that it seemed like it was okay to use Enhertu as a early treatment for patients with brain metastases based on that ESMO data. The drug that was sort of the default choice, maybe, or the approach that was maybe the default choice prior to that, was a combination using one of the TKIs. So the tucatinib, that's part of the Compass HER2 residual disease study. So that has been studied in patients with brain metastases. The HER2 Climb trial that was the registration trial for the combination of tucatinib, capecitabine, and trastuzumab for advanced or metastatic HER2-positive breast cancer included patients with brain metastases. The response rates and the PFS rates and the hazard ratios were all comparable with and without CNS mets. And so I think, prior to the sort of the increasing confidence about Enhertu's effect or ability to cross the blood-brain barrier, that combination with tucatinib, the HER2 Climb combination, was maybe a default earlier on, or a good option earlier on for patients with brain metastases. I think that pooled data from ESMO maybe suggests that Enhertu, deserves a serious consideration at that point also, and certainly, it's probably okay to be using it, and trusting that you're going to get a good effect systemically as well,
Yes.
outside the brain.
Absolutely, and it's good to have additional options for management of CNS metastases. Thank you, Dr. O'Neill. Our next speaker is Dr. Mariya Rozenblit, who is Assistant Professor of Medicine at Yale's University School of Medicine. Her breast practice is in the Greenwich region, and she conducts her research in New Haven and beyond. She will present an update on hormone receptor-positive breast cancer.
Thank you so much. I don't have any disclosures. So I'm going to be talking about some trials looking at, in the early stage setting, defining patients who are most likely to benefit from chemotherapy, how we're using CDK4/6 inhibitors in the adjuvant setting, some trials that are currently open at Yale, and then move on to advanced breast cancer and talk about some new targeted agents that we have, as well as some novel trials that are going on as well. So we know from the RxPonder trial that patients who had lymph nodes up to 3 positive lymph nodes, who had a recurrence score less than 25, when they were randomized to chemotherapy plus endocrine therapy versus endocrine therapy alone, we saw that there was no benefit for postmenopausal women for chemotherapy in this patient population, but there was a benefit in premenopausal women, and the absolute difference for the 5-year invasive disease-free survival was about 5%. What we don't currently know is whether this benefit that we're seeing is from the cytotoxic effects of the chemotherapy or because of the ovarian suppression when these young women go into early menopause from the chemotherapy. So the NRG is starting a national trial called BR009, and this is going to specifically look at this patient population of premenopausal women who have either node negative but high-risk clinical disease or N1 disease with a recurrence score of 0 to 25, and they're going to randomize to chemotherapy plus endocrine therapy, including ovarian function, versus endocrine therapy alone with ovarian function. So this is probably going to open at Yale very soon, so just something to consider for your patients, and it's going to be a very important trial to try to answer this question. We have 3 CDK4/6 inhibitors, palbociclib, ribociclib, and abemaciclib, and one of them, abemaciclib, is currently approved in the adjuvant setting. And so this is just a reminder that these drugs work by inhibiting the cyclin D1 CDK4/6 part of the pathway, which then prevents the cell cycle from moving forward and prevents cell division. So the approval of abemaciclib was based on the Monarchy trial, and this looked at node-positive, high-risk patient population. And so they either had more than 4 positive lymph nodes or 1 to 3 positive lymph nodes with either grade 3 disease or tumor size greater than 5 centimeter. And they were randomized to either endocrine therapy as standard of care or adding abemaciclib to endocrine therapy for 2 years. And what the Monarchy trial showed is that there was a significant benefit in invasive disease-free survival with the addition of abemaciclib. And the 5-year update was just presented at ESMO. And it looks like the absolute benefit in invasive disease-free survival is up to 7.6% with abemaciclib. So this is currently FDA approved in the adjuvant setting for this high-risk patient population that we mentioned, so equal to or more than 4 axillary lymph nodes on the pathologic staging, or 1 to 3 positive axillary lymph nodes and grade 3 disease or tumor size greater than 5 centimeters. Initially, this was approved with a Ki-67 cutoff, which we're no longer using because there was benefit seen regardless of the Ki-67. NATALY is a similar trial, but looking at using ribociclib in the adjuvant setting. So this trial included women who also have stage 2 disease. So it also included patients who are lymph node negative, and randomized them to standard of care endocrine therapy or ribociclib in addition to endocrine therapy. And ribociclib was given for 3 years. And so NATALY is also showing a benefit. And so the 3-year invasive disease-free survival rates, as you can see, 90 with ribociclib compared to 87 with just standard of endocrine therapy. And we're seeing a separation of the curves and hoping to see that they'll continue to separate with more follow-up. So ribociclib might be something that's approved in the adjuvant setting soon and might be a nice option for your lymph node negative patients that you are still worried about a risk of recurrence based on other clinical factors. We usually don't do neoadjuvant chemotherapy in hormone-positive breast cancer, but this is a recent trial that was just presented at ESMO, so Keynote 756, and this was looking at neoadjuvant chemotherapy in the hormone-positive patient population, considered high risk, so they had to have at least T1C/N1 disease and grade 3 disease. And they were given either dose-dense ACT, our standard chemotherapy, or dose-dense ACT with the addition of pembro. immunotherapy, and then the pembrolizumab was continued in the adjuvant setting as well. And interestingly, they did report that there's an improvement in pathologic complete response. So 24% with the addition of pembro to chemotherapy versus 15.6% with just chemotherapy alone. We don't have event-free survival data for this trial yet. That we'll find out eventually with continued follow-up, but very interesting results, and we might be seeing more incorporation of immunotherapy for these high-risk hormone-positive tumors in the future. So in terms of clinical trials that are currently open at Yale for the early-stage breast cancers, for the neoadjuvant setting, we have a trial called I-SPY. This is currently open only at the New Haven location, but hopefully will be open at other locations as well. And this is a trial where they're constantly updating the drugs that are in the trial. But currently for hormone-positive tumors that are at least T2, they have several endocrine therapy options. So lasofoxifene and doxepin, which are novel SERDs, so selective estrogen receptor degraders, and ARV-471, which we'll talk a little bit more about later. So if you have a patient who has a tumor on the larger side that you're considering neoadjuvant treatment for, perhaps to try to get them to a smaller surgery, this is a good trial to think about for those patients. We also have a trial open called NSABP-FB12, and this is a trial looking at novel HER2 signaling. So patients who are HER2 negative, but using this novel assay might have some HER2 signaling. They're adding trastuzumab, pertuzumab to the standard neoadjuvant chemotherapy. And then we also have a ctDNA monitoring study, which is an investigator-initiated trial that I'm leading. And so if there are patients who have residual disease in the triple-negative breast cancer cohort, or any patient who has stage 2B or above where you're worried about a risk of recurrence in those patients and you're interested in doing ctDNA monitoring, please reach out to me. We're very interested in looking at how useful is this in the adjuvant setting for surveillance, and also studying anxiety levels in patients and how the results affect physician decision-making process. On the adjuvant side, we have the DARE trial, which is screening patients for ctDNA positivity, and patients who are ctDNA positive are randomized to palbociclib plus endocrine therapy versus standard endocrine therapy. And we also have the EMBER-4 trial open, which is looking at patients who have received at least 2 years of standard endocrine therapy and randomizing them to imlunestrant, which is a novel SERD, versus standard endocrine therapy, to see if this novel drug is perhaps more efficacious and maybe has fewer side effects than standard endocrine therapy. So in the metastatic setting, in terms of current standard of care, we have CDK4/6 inhibitors, which are first line. And in the second line, we're hoping to find something targetable. So if patients have BRCA mutations, we have PARP inhibitors that are approved in this setting. If patients have PIK3CA mutations, we have alpelisib plus fulvestrant. We'll talk a little bit about CAPI, which is a novel AKT inhibitor, which might soon be approved for patients that have mutations in the AKT pathway. If patients have an ESR1 mutation, elacestrant is currently approved for this, and we'll talk a little bit more about that. There is some data from the MAINTAIN trial that switching endocrine therapy and switching the type of CDK4/6 inhibitor that they're on might allow you to get some more time out of the CDK4/6 inhibitor. And then, of course, if there are no mutations detected, everolimus and plus standard endocrine therapy is still an option. And we also have chemotherapy as well, and some antibody drug conjugates that we'll talk about a little bit later. So elacestrant is one of these new orally available selective estrogen receptor degraders. So when this drug enters the cell, instead of just blocking, it actually leads to degradation of the estrogen receptor. And so the approval of this drug was based on the EMERALD trial, which looked at patients who had received 1 to 2 lines of previous endocrine therapy, and also included patients who had received prior chemotherapy. and randomized them to elacestrant versus investigator's choice. And sorry, this is a busy slide, but what this is basically showing is that patients who had the most benefit from this drug were patients who had had a long duration on previous CDK4/6 inhibitor and who also had an ESR1 mutation. So patients with the ESR1 mutation had a progression-free survival of a little bit over 8 months compared to 2 months on standard endocrine therapy. And so this is now FDA approved for patients who have metastatic hormone-positive breast cancer with an ESR1 mutation. And it's easy to find out the status of the ESR1 mutations. There's several what we call liquid biopsy tests that you can send, including Garden 360 or Foundations. They'll both tell you the mutation status. So capivasertib is a novel AKT inhibitor. And so in the pathway, it's downstream of where alpelisib would act and upstream of where everolimus would act, which is an mTOR inhibitor. And there was a recent trial called Capitello that showed that patients who had received 2 lines of prior endocrine therapy and as well included patients who had received prior chemotherapy, when they were randomized to capi plus fulvestrant versus fulvestrant alone, there was a significant benefit seen with a median progression-free survival of 7 months with capi and fulvestrant versus just 3.6 with fulvestrant alone. So this is something that we're hoping will be approved soon and would be a nice option that's targeted for our patients. And the interesting thing about this drug is that it was shown to have less hyperglycemia, which is something that we worry about with alpelisib, so maybe a less toxic option for our patients. And then in the third line setting, we have antibody drug conjugates, as Dr. O'Neill reviewed. And for hormone positive patients, we currently have sacituzumab, which is approved. And so this is an antibody to TROP2. And the payload is SN38, which is a type of topoisomerase inhibitor. And so just like other antibody drug conjugates, when the antibody binds, the drug is released inside the cell, causes DNA damage leading to cell death, but also has this bystander effect where the drug is also released to neighboring cells. Tropion was a trial that was just presented at ESMO, and this was looking at one of these novel antibody drug conjugates called Dato-DXd versus investigator's choice. And this was in a pretty heavily pretreated patient population that had received 1 to 2 lines of previous chemotherapy. Dato-DXd, also antibody drug conjugate, the antibody is to TROP2, but the payload is slightly different. So DXd is deruxtecan, so also a type of topoisomerase inhibitor. And what this trial showed was that there was a significant improvement in progression-free survival of 6.9 months median progression-free survival on Dato versus 4.9 months with standard of care. So an exciting new option that we might be seeing approved soon for our metastatic patients. In terms of trials that are currently open at Yale, in the first line setting, we have a trial through SWOG that's looking at monitoring serum tumor markers in these patients to see if maybe we can image these patients less frequently. So this is a nice option for patients that are receiving CDK4/6 inhibitors in the first line setting. And the only requirement is that they have to have elevated tumor markers to be eligible. And here at Yale, we also have an investigator-initiated trial that I'm leading, looking at a novel assay developed by Biovica Divitam, which is looking at TKa levels. And so these levels are normally suppressed in patients on CDK4/6 inhibitors. So if they're inappropriately high, we're looking to see if this assay is useful for monitoring for medication adherence and possible medication interactions. In the second and third line setting, we have a trial through Celsuity, which is looking at this novel drug called gedatolisib and combining it with palbo and fulvestrant. There are actually 3 arms to this trial. If they have a PIK3CA mutation, they get alpelisib with fulvestrant. And there's also an arm with just fulvestrant as a single agent. And this new drug is a pan-PI3K and mTOR inhibitor. So they're very interested in seeing if it's more efficacious, especially in combination with a CDK4/6 inhibitor and fulvestrant. And then the Veritech trial is looking at ARV-471. So this is what's called a PROTEC. It's a drug that it works by proteolysis targeting chimeras. So it's using the ubiquitin proteasome system to degrade the estrogen receptor. So another estrogen degrader, but using a slightly different system to degrade the receptor. And this is an oral drug, so potentially a really nice option for patients going forward. And that's all I have. Thank you very much. Happy to take questions.
Thank you so much, Dr. Rozenblit. Yeah, we have a really good question in the chat. I could not have asked a better question, which is how to choose among the different CDK4/6 inhibitors in the metastatic setting. Yeah, that's a great question. So there was actually some survival data that showed that ribociclib has overall survival benefit in the first-line metastatic setting. So a lot of us have switched to using ribociclib in the first-line setting. We have data showing progression-free survival benefit with palbo, but not overall survival benefit. And with abemaciclib, we have promising data with overall survival data, but it's not quite mature yet. So we're still waiting to get the final data on abema. So I would say most of us start with ribociclib, and then if there's issues with toxicity, there can be QTC prolongation with ribociclib, then we switch to one of the other CDK4/6 inhibitors. Thank you so much, Dr. Rozenblit. We'll move on to our next speaker. Dr. Adriana Kahn is also one of the Yale breast specialists and also has a practice in New Haven, as well as sees patients within the phase 1 therapeutics program of Yale. She'll speak on triple-negative breast cancer.
Thank you so much for the introduction. Thank you for having us here. We're going to talk about advances and clinical trials that are available for patients with triple-negative breast cancer. And I'm presenting the data that we have as standard of care treatments for patients that have small, no negative tumors, as well as patients with larger tumors or node positive tumors, and then moving on to metastatic disease. So to begin with the smaller tumors that are node negative, we know that the standard of care for those patients, if they have small tumors up to 5 millimeters in general, we do not consider systemic therapy to be added to the treatment plan. However, once the tumors start to be slightly larger, we start to have a more gray zone. So between 6 and 10 millimeters, it's a consideration of systemic therapy, depending on risks and comorbidities, patient's age, the risk for disease spread, and also other features such as LVI or grade of the disease. And the decision is a little more clear once the tumors reach higher sizes. And for triple-negative disease, a higher size includes even a 1.1 and beyond centimeter tumor. So a T1C disease, we would in general recommend systemic therapy. However, for these smaller tumors, we try as much as we can to prevent patients from receiving anthracyclines, because we know that anthracyclines can be toxic, and in most cases, they are not actually necessary to provide similar benefits. So the more classic regimens that we have for patients with small or no negative tumors are docetaxel plus cyclophosphamide, or TC, chemotherapy, and we also have data on carboplatin plus paclitaxel, which can be sometimes preferred, but depending on toxicity profile. We have also alternatives. So if patients by any chance cannot receive anthracyclines because of cardiac toxicity or taxanes because of prior neuropathy, we also have some other regimens that are also effective, including CMF, which is an older regimen, less used, but still effective as an alternative. And we can also use, if by any chance they cannot get taxanes, we can also use anthracyclines if that's needed. And some oncologists for T1C tumors, sometimes they want to still give them anthracyclines, but that has becoming more rare. In terms of data for the TC chemotherapy with docetaxel and cyclophosphamide, we recommend 4 cycles in the adjuvant setting, because we know that 4 versus 6 cycles does not really bring any additional benefit to add those extra 2 cycles. And we know that taxanes can bring toxicity, especially with peripheral neuropathy. So doing less is more if we have similar outcomes. And as we can see here, relapse-free survival and overall survival are very similar from those two regimens. And this trial assessed patients with up to 3 positive nodes. So it's not just for the little tumors, but even for tumors that are a little more extensive. So we know that this is good enough and probably more than needed. So 4 cycles is enough. And we also have data with carboplatin and paclitaxel for 6 cycles, which was compared in an Asian study with FACT-T, and they did not see difference in outcomes, in survival outcomes for those 2 regimens, and therefore that was considered an alternative to an anthracycline-free regimen and also another option in addition to docetaxel and cyclophosphamide. So we've seen patients getting that sometimes as well, and that's also some of the clinical trials arms of choice as standard of care. When tumors become larger or they have node involvement, and this is a general rule, of course, all the trials have specific T's and N's that are listed for inclusion criteria, but just to think overall, it's if the tumors are more than 2 centimeters or if the tumors have node involvement, then we recommend not just systemic therapy, but also neoadjuvantly, because at this time, although the data so far, classic data had been that neoadjuvant versus adjuvant therapies wouldn't make a big difference. Now we've become a little smarter in terms of tailoring therapy. So if patients do neoadjuvant therapy and we can assess their response to treatment, we can do less if they have complete response or more if they still have residual disease. And we can also improve some surgical outcomes by doing smaller surgery. So from those perspectives, it's becoming more standard of care. Even for tumors that are small overall, like with 2-point-something centimeters or 1 node or so, to just still do the treatment neoadjuvantly, because we know that we're not missing in any sort of survival benefit. And we have those added benefits. So the classic regimen that we use currently that is approved for tumors that are larger and or node positive is with the addition of immunotherapy in the form of pembrolizumab plus chemotherapy. And the chemotherapy of choice for this trial that I'll show soon was carboplatin plus paclitaxel, followed by doxorubicin plus cyclophosphamide. And those were in addition to ongoing pembrolizumab in the neoadjuvant and adjuvant setting. So this is the Keynote 522 trial that was performed as a phase 3 randomized double-blind study that randomized patients between neoadjuvant pembrolizumab with chemotherapy versus patients with placebo plus chemotherapy. And they were followed by surgery with adjuvant pembrolizumab in the immunotherapy arm and placebo in the placebo arm. And they did show a significant improvement in not just pathologic complete response, which is something that we can see faster in the surgical specimen assessment, from 51 to 65% increase in PCR rate, but also event-free survival. So in the initial publication, the data was shown that the event-free survival, which accounts for recurrence and death, showed that there was a benefit from 85 to around 91%. And there was slightly more grade 3 adverse events, but none that were clinically limiting or that would take away the added benefit in terms of survival for such a harder disease to treat. And therefore, this became standard of care. And as an ESMO update, the meeting just happened this past weekend. At a longer follow-up now of 63 months, we have patients with events. So in the pembrolizumab, we had 18.5 patients having an event versus 27.7% of patients in the placebo group having an event. So still consistent with the initial benefit. And we have the median was not reached just yet, and benefit was consistent across all the subgroups. So we are still encouraged by those results because they're seeing that at long term, this is still a great choice and a great addition to the neoadjuvant treatment. When we have residual disease followed by the neoadjuvant systemic therapy, we have a few options of how to manage those patients. So we know that they had some response, but the disease still persisted. And if the disease persisted in the breast, then the idea is that some metastatic cells or clusters of cells could still be persisting systemically, and that's what we are concerned about because that's what impacts survival. So the CREATE-X was a study that assessed the addition of capecitabine versus placebo in the adjuvant setting for patients who had neoadjuvant treatment and had residual disease. It was a trial that was done for all comers, hormone positive and hormone negative disease, but the results were positive due to the triple negative disease group. So it showed that adding capecitabine in the adjuvant setting, if patients had residual disease, that was shown to improve disease-free survival and overall survival, and therefore it became standard of care. And we also have data for patients with germline BRCA mutation with the Olympia trial, that if they do have residual disease after neoadjuvant therapy, we can also add olaparib, which is a PARP inhibitor, also with benefit in survival. So those are options that we have to consider for patients that in the adjuvant setting have residual disease, so that it's how we can try to tackle that increased risks that they have, as we know that residual disease does increase the risk for impact on event-free survival. So in terms of future perspectives in the early stage setting, we have many unanswered questions and things that are upcoming, so are important to mention. So can we use novel agents in the neoadjuvant setting? So can we use ADCs instead of chemotherapy? Can we use PARP inhibitors? Can we merge those with immunotherapy and try to remove a lot of the chemotherapies that we still use in the neoadjuvant setting to achieve similar benefits but with less toxicity, just by having a smarter way of treating cancer? Another question is the classic regimen included, the Keynote 522 included pembrolizumab with chemotherapy, and that was including anthracycline. And we know that the benefit of immunotherapy to chemotherapy is very extensive, including with other phase 2 trials that showed similar rates of PCR, even if you did not give them anthracycline. So the question is, are anthracyclines needed now that we can add immunotherapy to the systemic therapy in the neoadjuvant setting? The other question also regarding immunotherapy, the Keynote 522 trial added adjuvant pembrolizumab up to a whole year, and that was regardless of PET-CR or residual disease. And we know that immunotherapy, of course, it's overall well tolerated, but can also have autoimmune side effects that sometimes can be debilitating or even life-threatening. So once patients have pathological complete response to neoadjuvant therapy, do they still need to receive a whole full year of immunotherapy, or can we skip that to prevent toxicity and keep similar benefits? And another question, like Dr. Rozenblit mentioned earlier, is can we improve monitoring for disease recurrence, and can we use that information to make changes in therapy and plan for patients? So some of our current neoadjuvants or adjuvant studies that we have here at Yale, Dr. Rozenblit mentioned the I-SPY trial, and it is a trial that dynamically adds novel agents to the neoadjuvant setting, either to the standard therapy or in replacement of if patients develop great responses. So that's a trial that is mostly always available for our patients. As she also mentioned, we have a trial adding anti-HER2 therapy for patients that would receive just chemotherapy if they are positive for HER2 in this newer assessment. We also have data of, a trial of the use of adjuvant antibody drug conjugates. So the trial we have is adding datopotamab deruxtecan with or without immunotherapy versus investigator's choice of therapy in patients that have triple-negative breast cancer but had residual disease after neoadjuvant therapy. So instead of classic regimens like capecitabine, can we do more? Can we do ADC and maybe immunotherapy in the adjuvant setting? Another interesting trial that we have is adding PARP inhibitors for patients with BRCA mutation in addition to immunotherapy in the neoadjuvant trial. So some patients would have PET-CR in the neoadjuvant setting and then therefore wouldn't be eligible to receive PARP inhibitors in the adjuvant setting. So this trial is bringing the option of exposing them to a drug that makes sense to their disease because they have BRCA mutation. And maybe that would be enough to achieve similar benefits and sparing them from all the whole list of chemotherapy and immunotherapy drugs that we know we do as standard of care with the Keynote 522 trial. To answer that question of do we need immunotherapy in the adjuvant setting if patients had PET-CR, we have the optimized PCR trial, and they are randomizing patients to receive immunotherapy versus not if they have PET-CR. And we have Dr. Rozenblit's trial of circulating tumor DNA assessment in patients with triple-negative breast cancers with residual disease after standard neoadjuvant therapy to understand if that can trigger additional testings, additional therapy changes, and if that would impact patients' outcomes. In terms of triple-negative metastatic disease, first thing we do is to assess PD-L1 status. That is based on data that I'll show that if patients have PD-L1 positive based on CPS, we treat patients in the first-line setting with chemotherapy plus immunotherapy. And later lines, they can get additional chemotherapies or antibody-drug conjugates that are currently FDA approved. And if they are PD-L1 negative, in general, first-line setting is given with regular standard chemotherapies. And we can also keep those additional chemotherapies and antibody-drug conjugates in later lines. We also know that assessment of tumor mutation burden or microsatellite instability, mismatch repair deficiency can also open some doors for immunotherapy drugs that are approved agnostically for those patients. So those are important to know firsthand, so you prepare yourself for the use of immunotherapy for your patients. And this is the data for the first-line setting. So we have the Keynote 355 that added chemotherapy and immunotherapy together in the first-line setting for all comers, but the trial was positive for patients with CPS 10 or more, which is considered the CPS positive group. And pembrolizumab was added to either paclitaxel or gemcitabine plus carboplatin. And it showed an improvement in progression-free survival from 5.6 to 9.7, and overall survival from 16 to 23 months. So significant, especially in such a group with a huge area of need of improvement. As an ESMO update, we have data from the Begonia trial, which is a phase 1b, phase 2 study that assessed the benefit of datopotamab deruxtecan, which is also an antibody-drug conjugate, plus durvalumab, which is an immunotherapy agent in the first-line setting for patients with advanced metastatic triple-negative breast cancer. And as the data cutoff assessment happened just now, they had a confirmed overall response rate of 79%, including 10% patients having a complete response and 69% patients having partial responses. That was seen regardless of PD-L1 expression, and the median duration of response 15, median PFS 13, almost 14 months. So very encouraging data. And adverse events were most common ones were nausea and stomatitis, which are known to the datopotamab deruxtecan. And serious events happened in 23% of the patients. So this is an early phase study. Of course, we need larger data to see if those numbers will change, but overall very encouraging data because it's a first-line treatment without any classic cytotoxic chemotherapy. It's with an ADC plus immunotherapy, and for all comers. So that would be interesting if that moves forward and matures to be positive. Beyond first-line setting and beyond the correct regular options of chemotherapy, we have the antibody-drug conjugates. So we have sacituzumab govitecan that was tested versus single-agent chemotherapy of physician's choice. So they randomized almost 530 patients between the two groups, and they saw a huge benefit in progression-free survival from 1.7 months with the standard of care, which is very little, to 5.6 months, which is still little, but increased substantially from the standard of care options. And with overall manageable adverse events, of course, it's an overall toxic regimen, especially with cytopenias and GI toxicity, but some patients tolerate it very well, and indeed the benefit is significant. So that is a common choice in the second-line setting and beyond. And we also have trastuzumab deruxtecan, which is presented already to you in the HER2-positive setting, but this was also shown to be positive in patients with HER2-low breast cancers, and those include patients with hormone-positive and hormone-negative disease. But I brought here the data on the hormone-negative disease because that is a classic triple-negative breast cancer patient. So look at the separation of the curves for that population, showing a benefit in PFS from overall 3 to 8.5 months, and overall survival from 8.3 to 18.2 months. So substantial. This trial was the one that was applauded by everybody when it was presented in the plenary session. So it is a great option, and that puts us a little bit in question in clinic and in conferences often of how to sequence those better, because we know that they're both effective and they have different side effect profiles. So those are things that we use to try to think about which trial and which drug to go first. Also, now Dr. Neil presented data on CNS disease involvement, so we can use that as well as a guide. So what are the future perspectives? How can we sequence those ADCs? Can we give ADCs in the first line setting? Can we add novel agents to patients that are either positive or negative for PD-L1 and in beyond progression in the first-line setting? And what are the new agents coming on early phase clinical trials? So here at Yale, we have the datopotamab drugs, TICON versus investigator's choice in patients in the first-line setting who are not candidates for PD-1 or PD-L1 inhibitors. So that is, again, first-line setting without chemotherapy, classic chemotherapy. We have a trial with eribulin in combination with a PI3 kinase inhibitor, copanlisib, which is technically an indication that is currently only approved for patients with hormone-positive disease. So would PI3 kinase inhibition improve outcomes in triple-negative disease as well? And we have many phase 1 clinical trials, and that's something that I actively work on by working in the early phase department. We have many novel IDCs with different targets that are being tested. We have novel immunotherapy agents that work beyond just the PD-L1 pathway. We have also additional agents that are being developed with novel technologies, including, for example, a trial with the BioNTech, which is the mRNA that we know for the COVID vaccine, and they encode IO2, which is an inflammatory marker. So novel things that how can we create new drugs that are in addition to the standard things that we already have to maybe open more doors for our patients. And also newer drugs in the DNA repair damage pathway. So BRCA and beyond BRCA, most of the current therapies are only approved for BRCA, but we have a list of other DNA damage mutations that are currently orphans. We don't have therapies to target patients with, and now we have newer trials trying to see if those would happen. And in our cell therapy department, we have a CAR T cell therapy trial for patients with triple-negative breast cancer, which is an innovative thing because this is indeed seen mostly for hematological malignancies. So we have that now available for solid tumors, including triple-negative breast cancer. So those are the latest data that we have from trials here at Yale, and I thank you so much. And if anyone has any questions, please feel free to ask.
Yes, thank you, Dr. Kahn. We do have a question on local regional therapy, including breast surgery in the setting of stage 4 disease, if you want to start taking that.
Yeah, so I can respond. That's a question that really doesn't have a true answer. In general, we, as standard of care, we do not recommend mastectomy because we know that stage 4 disease, unfortunately, doesn't have a great outcome. And we know that even if we do mastectomy, we might still have residual disease systemically, and not too far from the date of surgery, you might have progression of disease. And then you have now a patient that has a huge surgery and now disease progression. So that most of the times it's not something that we classically recommend. We do know that there is data and some studies showing what is the benefit of treating patients more aggressively if they have oligometastatic disease, or if you have a local tumor that is such a burden that patients have ongoing pain or discomfort that can be done in the palliative setting. Of course, that could also be considered, but I think that's a very difficult discussion and decision that should be always held, if possible, with a multidisciplinary approach. So bringing together the oncology team, surgical team, radiation team, because we might have other ways to treat local tumors when they have stage 4 disease, maybe with radiation or maybe with more effective systemic therapy. So a question without a clear answer, but as standard of care in general, we do not recommend.
Thank you so much. Go
Can I
ahead.
just add one thing? The only thing I would add is, so the SWOG group is actively working on a concept in this space, looking at aggressively treating specifically de novo oligometastatic disease. So patients who present with less than 5 lesions at the time of diagnosis, and they're de novo, so meaning they haven't received previous therapy for metastatic breast cancer, so maybe they're more responsive. And so hopefully eventually there will be a trial to actually answer this question, randomizing patients to just systemic therapy versus systemic therapy plus surgery and radiation. But up until that trial becomes active, I wouldn't recommend surgery for these patients.
And I think as an overall reminder, we always have phase 1 studies for all breast cancer types. So if we have patients that have received many lines of therapies or have toxicity with the standard of care options, please always consider referring them to our phase 1 team.
Thank you, everyone, to the audience, as well as our wonderful panelists. Thank you for joining us on Yale Smilow Shares. Thank you so much. Good night.
Thank you.
Good night, everyone.
Yeah.